One number. That's all it takes to save your life, or silently end it. Your blood pressure reading. You've seen it hundreds of times. But what if I told you that the number your doctor is telling you to hit might actually be the wrong number for your body? Right now, the world's top medical experts are fighting each other over what your blood pressure target should be. And the gap between their recommendations? 20 points. That 20-point difference could mean the difference between a heart attack and a dangerous fall that kills you just as fast. Today, I'm going to walk you through the exact framework doctors use with their own patients, the questions you need to bring to your doctor, and the hidden dangers of getting this wrong in either direction. Stay until the end, because the last risk factor I cover surprises almost every single person who hears it. The war between medical experts. Here's something your doctor probably never told you. The American Heart Association and the American College of Cardiology, two of the most powerful medical organizations in the world, recently said your blood pressure should be below 130, and if you're high risk, they want it below 120. But your primary care physician may be following completely different guidelines. The American College of Physicians says 135 to 150 is perfectly acceptable, depending on your overall risk. Same patients, same evidence, 20-point difference in targets. That gap isn't just a number on paper. That gap determines how many medications you take, how aggressively your doctor treats you, and potentially whether you survive the next 5 years. So why are the experts so divided? It all comes down to one single study that shook the entire medical world. The SPRINT trial, the study that changed everything. In 2015, a massive clinical trial called the SPRINT trial published its results. Over 9,000 adults, average age in the late 60s. Researchers split them into two groups. One group targeted a blood pressure below 120. The other group targeted below 140. The results were stunning. The group that kept blood pressure below 120 had fewer heart attacks, fewer strokes, fewer cardiovascular deaths, and, this is the number that made headlines, a 27% reduction in all-cause mortality. 27%. That's enormous. And that's exactly why cardiologists around the world grabbed this study and used it to push for more aggressive blood pressure targets. But here's where it gets complicated, because the fine print of this study tells a completely different story. The fine print nobody talks about. SPRINT had a massive flaw that most people never hear about. The study excluded diabetics. It excluded people who had prior strokes. It excluded anyone living in a nursing home, anyone with significant frailty, anyone who was already weak or unwell. In other words, SPRINT only tested aggressive blood pressure lowering on the healthiest, most resilient older adults. The exact people where this question gets dangerous and complicated? They were never in the study. And then came the ACCORD trial, which specifically studied aggressive blood pressure lowering in diabetic patients. The result? No clear benefit. The protection SPRINT promised simply did not show up. So when someone says everyone over 60 should push their blood pressure below 120, that is not what SPRINT showed. SPRINT showed it works in healthy, active, resilient older adults. Period. There's also a measurement problem. SPRINT used a special automated blood pressure measurement method that reads 7 to 10 points lower than a standard office reading, which means SPRINT's target of under 120 may actually correspond to 130 in a real-world doctor's office. Even the American Heart Association quietly acknowledged this later. And one more thing, SPRINT was stopped early because the benefits looked so strong. But studies stopped early tend to exaggerate results. Thoughtful. A later Cochrane review flagged this and noted that SPRINT's mortality reduction looked like an outlier in their own meta-analysis. Same data, very different conclusions, and now you understand why. The hidden dangers of pushing too low. Here's the part that genuinely shocks people. Lowering blood pressure too aggressively doesn't just cause side effects. It can kill you, just in a different way. The biggest risk is falls, specifically, falls that lead to hip fractures. The 1-year mortality after a hip fracture in an older adult can be as high as 25%. That is higher than many cancers. And once an older adult breaks a hip, returning to their previous life is often impossible. months of limited mobility, loss of muscle, loss of independence. For many, it's the beginning of the end. But falls aren't the only danger. Pushing blood pressure too low can cause kidney injury. It can cause syncope, sudden loss of consciousness. It can cause dangerous drug interactions from stacking multiple blood pressure medications. And then there's the one risk almost nobody talks about: cognitive slowing. When blood pressure drops too low, your brain simply doesn't get enough blood flow. Thinking gets slower, memory gets foggier, and that brain fog often gets misdiagnosed as early dementia, when in reality, it's just overtreated blood pressure. So the real trade-off here is not heart attack versus nothing. It's heart attack versus hip fracture. It's stroke versus kidney failure. It's cardiovascular death versus a fall that causes a fatal brain bleed. The answer is not to back off from everyone. The answer is to match the aggressiveness of treatment to the right person. The framework doctors use, and what you need to ask. So how do you actually figure out your number? The first thing to evaluate is functional status. Can you walk a quarter mile without stopping? Can you climb a flight of stairs? Can you get out of a chair without using your hands? Do you live independently and stay active? The fitter and more resilient you are, the more aggressive your blood pressure target can be. Second, medication burden. How many pills are you already taking? Adding another blood pressure drug to a long list creates real risk of dangerous interactions. Third, kidney function. And not just where your kidneys are today, but where they were 6 months ago and a year ago. Aggressive blood pressure lowering can accelerate kidney decline in some people. Fourth, and this one is critically overlooked, the diastolic number. That's the bottom number in your reading. If the diastolic drops below 70, or especially below 60, the risk of coronary heart disease actually goes up. Here's why. Your coronary arteries, the vessels that feed your own heart muscle, fill during the diastolic phase. If that pressure drops too low, your heart doesn't get enough of its own blood supply. And connected to this is pulse pressure, the gap between your top and bottom numbers. A blood pressure of 140/80 gives a pulse pressure of 60. As that gap widens with age, it signals stiffer blood vessels and higher risk of cardiovascular events. Never just watch the top number. The full picture matters. The real target ranges by person type. Here's roughly where the evidence lands, depending on who you are. If you are a healthy, active adult between 65 and 80, no frailty, no dizziness, no serious kidney disease, the target to discuss with your doctor is a systolic of 130. And if you tolerate that well, pushing toward 120 or even slightly below may offer additional cardiovascular protection. If you are frailer, mobility issues, dizziness when standing, kidney disease, or already on multiple medications, the safer starting point is closer to 140/90. Going lower before your body is ready creates more danger than it prevents. If you are over 80, this is where everything slows down. The typical target range is 135 to 145 systolic, adjusted based on your symptoms and tolerance. And the number one priority becomes simple. Avoid falls, avoid injuries, protect your independence. Warning signs that your blood pressure may be too low: lightheadedness, persistent fatigue, brain fog, muscle cramps, worsening kidney function. These are not just side effects. These are your body sending a signal. And one absolute rule: never stop blood pressure medication on your own. Always discuss any changes with your medical team first. Blood pressure is one of the most solvable problems in medicine. Nutrition, exercise, stress reduction, these alone can move the number significantly for many people. And when medication is needed, there are excellent options that work. But the piece that gets missed over and over again is the individualized approach. Your number is not the same as your neighbor's number. Your target is not the same as the person sitting next to you at the doctor's office. The framework is simple. Know your functional status, know your kidney function, watch your diastolic, monitor your symptoms, and have an honest conversation with your doctor using exactly these questions. If this video helped you understand your blood pressure in a way no one ever explained before, share it with someone you love, because this information could genuinely protect their life. And if you want to learn the early warning signs your heart sends before a cardiac event, that video is right here. Watch it. It could save your life.